All right. Hello, this is Jill, and I'm here to talk a little bit about some of the things that I experienced at my trip to CSM this year in Houston. To start off, I'd like to talk a little bit about a session that I attended that related to pediatric PT. And the session that I attended was titled Pain Games, Virtual Reality, and Pediatric Chronic Pain, which is pretty self-explanatory, but it explored the usage of virtual reality in managing patients who are coming in with different types of chronic pain. So the presenters that were giving this presentation today were Dr. Kim Clarno and Dr. Serena Majmundar, who are both coming from the Stanford Children's Health System. Dr. Majmundar works specifically with children who have hypermobile EDS, central sensitization, and CRPS. So we were able to talk a little bit about a couple of cases of patients that she worked with in terms of her success with virtual reality with them. And there were a ton of interesting facts that were discussed throughout this presentation, but I just want to give a couple of those. So one of the ones that was most striking to me when we were talking about the background of pediatric chronic pain and things that relate to that was that opioid prescription after pediatric surgery actually doubled the risk of a future hospitalization for substance usage in the future of a child's life. So that's huge to me because we know that hospitalizations due to substance abuse are already very difficult to deal with, and they're very avoidable. And in the adult population as well as the pediatric population, it's very common for there to be instances of like addiction or other problems after being prescribed opioids after surgery. So there's been a long debate of other ways to manage pain successfully post-surgery and other reasons. So that goes just as well for chronic pain because we don't want to just have just a simple pharmacological treatment plan for people who are experiencing chronic pain because then this could lead to other issues down the line. So then as time went on, we discussed some psychosocial factors that affect the pain a child experiences, which some included emotions, thoughts, and memories, which all made total sense to me. I feel like we've discussed those kinds of things to a large extent in my life, especially in PT school. But a couple of other factors that I was unaware of were a topic or a theme called parent protection, which was defined as frequent check-ins and accommodative behaviors can also increase a child's perception of their pain, as well as the parents' distress themselves about the child's pain can also increase the child's perception of pain. And these last two factors were particularly interesting and surprising to me, especially the parent protection aspect, because also earlier in the talk, we spoke about how one of the risk factors for a patient to develop chronic pain is having poor caregiver health. So I kind of took that as the patient has a caregiver who is unable to give them as much attention as they may need in this growing phase of their life. So it surprised me that when someone has less ability to care and then also having too much checking in, too much caring almost, can both exacerbate pain in a child. So it seems to me that we need to kind of find like a balance to best handle a child's pain in any circumstance. Which is obviously easier said than done. But continuing on, we also discussed that the gold standard currently for treating chronic pain in pediatrics is, like with most things, a multimodal interdisciplinary model of care. And within that, VR is a growing tool that is appealing to both children and teens, as well as I'd argue adults. And it addresses the healthcare burden that is currently in the world. And it's also as rewarding as it is measurable. So one of the games that we talked about a lot was one where a patient would have a VR headset over their eyes and they would hold two items in their hands. And then they would be seeing kind of like these 3D blocks coming at them in both sides. And they would use their hands to kind of slice it. Like I would think like Fruit Ninja, we used to play on our iPads as kids. But yeah, so as a patient's playing that game, they're able to see instant feedback on how well they're doing based on how many blocks they're able to successfully smash. And then at the end of rounds, they get scores. So over time, they can kind of play against themselves, try to beat their high score. You could even possibly make this kind of like a leaderboard activity, depending on what the type of therapy is, what the setting is. So that's really helpful for motor learning and to encourage and motivate these patients to be adherent with their plan of care and excited to come back and continue to do therapy with us. Also, VR is non-invasive, and the intervention can be customized to the patient's ability while continuously encouraging progression at the same time, which is something that's difficult when we as PTs kind of set up an intervention just like with physical items, because if we want to modify something, we have to kind of halt that activity and then restart, change some things, and then see how it goes. And there's a lot of trial and error. Whereas with this kind of a thing, a patient can just continuously give it their all. And then as they give it their all, the game can become not easier, but they feel like they're playing it more successfully. For example, we did discuss a patient who had some mobility deficits within their upper extremities. So playing this exact game where they break the blocks was difficult because the patient had trouble moving their arm around and trouble gripping the nunchuck in their hand. So as the sessions went on and as time continued through PT, the patient was amazed to see how much range they've gained, range of motion at the shoulder, at the elbow, and then strength at the hand, as well as other strength in other muscles around the shoulder, because most of the time these games in VR are played in standing up if possible. So when a patient's able to stand up and move their arms around and walk around, they're also not only getting range of motion benefits, but also strength benefits because they're going against gravity. So it kind of has many benefits. And one benefit also that isn't so measurable is just the aspect of distraction that a game has for these patients, because they kind of feel like they're like immersed in the game, and then they can sometimes forget the pain that they're in. And it's just, it almost goes back to that pain science understanding, where with nociplastic pain, which also is a big contributing factor to a lot of chronic pain in peds and elsewhere, when those signals are able to be blocked, they don't feel as much pain and they're able to perform better in therapy. And it's motivating for the patient and the PT. So we got many benefits there. And then this is really exciting for me because I feel like getting a VR headset and the nunchucks at the very minimum is probably not that unattainable. So, and it's because I feel like it is applicable to peds and adults, it would be great to have in any kind of setting. And I plan to probably work in outpatient orthopedics or sports. So I will probably be working with a variety of patients of all ages. And I feel like I could probably interest many patients in trying to do some VR with me. So if I could get the funding to do that, I think it would be a lovely intervention for many different people with many different conditions. So it's got quite an applicability. And then the exhibit hall. I walked around the exhibit hall quite a bit at CSM as well. And I got to see a lot of cool stuff. But the thing I wanted to talk about today does not relate to VR, but it is really useful in early mobilization for our younger pediatric population, as they're in the month stages of their age and they're doing their early mobilization. And I got this little pamphlet to show you guys. So it was called Baby G, and it's just called an early mobilization system that consists of a harness that attaches to the pediatric patient, and then the harness is attached to the ceiling with this cute little cloud that helps de-weight the child as they're doing the early mobilizing. So they define it as a dynamic body weight support system that can offload between 2 and 20 pounds of a child's weight as they practice independent sitting, crawling, standing, and stepping. So we know that our patients in this early stages of life sometimes don't need to go through all of these milestones, but when they are working through these milestones, sometimes they kind of develop a dominant side or a favored side, and then there can be like a strength deficit on the other side. So with this kind of a system, I think it'll be really useful for these patients as they can kind of work without all of that weight of their body, and they can practice doing their stepping, doing their crawling, and getting all four extremities to be part of that motion. And I think because of the price of this this technology and how large it is, it would probably be best suited to be used in the clinic. So if I were working in a peds clinic, this would be really useful. And I think it's amazing also because due to the de-weighting from the machine itself, the therapist then gets less fatigued, and then we can do the intervention for longer. And also the child, therefore, as they get fatigued, we can take more weight off, and then they can continue to do their therapy for even longer. So this could be a really useful tool in the clinic, in a pediatric clinic, that I would love to be able to use one day in my practice if that's where I end up. And yeah, I'm not so sure about adults, but it does remind me of in the neuro rehab units where they have those ceiling walking harnesses where people can walk, for example, like after a stroke, which I think is also very cool. So love to see it. Everything kind of ties together. And yeah, thank you for listening. I hope you enjoyed. And I hope to see more research in the future about VR with pediatric patients.